Good afternoon, ladies and gentlemen, and a warm welcome to this session on, more generally speaking, I would call it metabolic balance. So the lower end of metabolic balance might be acidosis, the upper end is alkalosis, of course. But this session is now focusing on acidosis, and as you know from the Greek gods mentioned, before you do anything, you have to find a clear diagnosis and to have an idea of what you are going to do. So, and I do not know anybody else, actually, who is more able to explain you the balance in a sense of acidotic imbalance and to get back to balance than Luciano Gattinoni. So it's a pleasure, Luciano, to open this session with your thoughts and your knowledge, deep knowledge. I still admire it today.
Okay, good morning. Good morning to everybody. Well, I think when you give acidosis, its impact, is quite big. Big topic, and I would like to just touch 2 or 3 things that I think in my career stress me a little bit, which maybe are not completely conventional. And I think because the real aim of whatever conference or lecture is to stimulate in 10% of the audience some curiosity to go more in depth on what has been said. I hope to succeed, but it's not no conflict of interest for this lecture. So, acid-base imbalance, why it occurs? Well, we have a lot of acid. We have volatile acid. We have a big production, about millimoles, 15,000 millimoles of CO2 per day, and lactate contribute about 1.5. Lactate is not bad. Lactate is a part of normal our metabolism. I will touch this in point in particular. But anyway, this explains why you have a tremendous acidosis if you stop breathing, because it takes a very short time to have this load of carbonic acid and to decrease the pH. While the non-volatile acid and the kinae take care of this, which are phosphoric, sulfuric, and others. More or less, we have a charge is the order of not of the 1,000, but of the hundreds. So this is the reason why, as an example, renal insufficiency develop acidosis, but quite slowly with time. Then we have the classical, the basic acidosis, if I add to the tomb of rule, you may make a diagnosis in 5 minutes, because you may say, okay, is lactic, and you can immediately suspect if acidosis is from lactic acid or not. Look at the pressure, look at the PO2, etc., etc. Is glucose, maybe acidosis, ketotic acid, is very easy. You take glycemia and you see it's not. Is a kinae, look at the creatinine. And if you don't have one of the 3, that means somebody gives something else. So you can make the diagnosis of metabolic acidosis in something as 45 seconds, and the charts maybe in the urine also. Now, in the critical ill, we have a sort of, the acid production is usually increased because in some, at least in some stage of sepsis and so on, we have an increased energy demand, so we have an increased metabolic rate, an increased production of CO2. The catabolism of protein is increased, maybe 2-3 times compared to normal, so the non-volatile acid increases a lot, so the total acid load is increased, and you have to take care of this. The body has to take care of this, with 2 main organs, which are lungs and kidney. Now, and this is the class, we concentrate a bit on lactic acidosis, which is the most common. And I think we were taught since we were babies that we have some problem when you do not have oxygen. The pyruvate, the glucose goes to the lactate because you are in lack of oxygen. Lactate is a terrible thing, get into the blood, and we have the problems of acidosis. But now, let's take a molecule of glucose. Molecule of glucose, if I remember correctly, are 6 carbon, 12 nitrogen, and 6 oxygen. Now, if you divide by 2, without losing anything, you get exactly the same number of protons, the same number of carbons, and the same number of oxygen. That means the natural end of the glucose is not the pyruvate, is the lactate. And in the last 10, 15 years, have been developed, I think, a very meaningful approach to the problem, in which is very briefly summarized here. Let's see. This is lactate. We have the glucose, you know. You have the anaerobic production of energy. We have some production of protons, which are immediately utilized. And we have the lactate. The lactate goes into mitochondria and have a different destiny. Lactate have substantially 3 possibilities, or become alanine, or get into the inner membrane of the mitochondrion. Then we have the transformation in pyruvate, and at the end you have the acid, the Krebs cycle. Each of these steps may lead to increased production of lactate, because the lactate, the hyperlactate, so the acidosis from lactate, occurs when the oxidation capability of lactate is overcome. And this may happen because of glycolytic flux. We give adrenaline and so on. Sometimes we have increased production of lactate which exceed the capability of eating lactate. Determine deficiency, which is allow the entering in the Krebs cycle, and the respiratory chain impairment. I may have, during the sepsis, I have modifications of one of the beautiful enzyme which allow the electron jumps and the energy to be transferred into within the mitochondria. And at the end, we have a low oxygen concentration. But tell me, how many times you have a patient that start maybe with lactate of 6, and then a septic patient, the lactate goes 5, maybe 4, and lactate stay there, maybe for days. On Wednesday is 4, on Friday is 5, and so on. Try to imagine that our tissue have a tremendous capability of eating lactate. And when we have a part of the body, we produce more lactate, and I put lactate in the blood, the capability of the other organs to eat lactate are increased. Depends, so we reach a steady state in which the production is equal to the consumption. How to assess the acidosis? Okay, let's go. This is a nice picture. What do you see here in this picture? You see, I mean, the first impression that you have a nice woman, a young baby, no, young girl with a head here, okay? But if you look, you may also see a man. This is the nose. These are the mustache. And you may have also see a tremendous old woman. This is nose. This is the bush. This is the man. So we have 3 figures. Depends how do you look. And the acid-base approach is exactly the same thing. And people say, okay, what is the strong ion difference? Great. No, it's Sigar Andersen and Vaslike. Great. Or Boston approach was done in the 50s, 60s. We have a tremendous fight in the 60s between, not with the strong ion difference become later, but between Boston and the Swedish and Danish approach. Why we were speaking exactly about the same thing. But just we were looking at the same picture from different angle of view, which is nothing else than the culture. The culture are the glasses that we wear to look at the reality, I think. And so the most popular, what is the good thing of strong ion difference? Is not to count all the electrolytes, but to appreciate one concept, that we cannot approach the acid-base equilibrium without considering the general framework. And the good things of the strong ion difference is that one, I think, that you can see. This is very difficult to. Okay. You can see this is the frame, positive, negative, and this is what was like called the buffer basis. So the different strong and low strong ions means the ions that when are in the system do not change. Sodium lose one electron and chlorine take one electron. That's it. The only thing that can change this concentration is the kidney. Okay? Then we have the weak electrolytes or the weak acid, which are here and were called buffer base. And this is the space of the buffer base. And the buffer base, Carl Anderson, when he was preparing his thesis of laurea, said, okay, what is really the buffer base? Buffer base is nothing else, the base excess is the excess of buffer bases. I have more buffer base than I expect. Deficit of buffer base excess negative, I have less buffer base than I expect. Very simple concept. Base excess refers to this. So all the Danish school concentrate in analyzing what's happening in this domain. Strong ion difference looks at whatever happens in the complete domain. And the Boston look at what? The body reacts to the variation of these two, of these components. So, and this is the base excess versus the strong ion difference. Strong ion difference is equal to the buffer base. The base excess will be equal to the difference between expected strong ion difference and actual strong ion difference. It's exactly the same thing. So if I have minus 10 of base excess, means that my strong ion difference is decrease of 10 compared to the expected. I expect 42, I found 32, 32 minus 42 is minus 10. So it's not question, but the beauty of the strong ion difference is that obliges you to consider the general framework in which the acid base occurs. And let's say, everybody looks base excess and they look in the arterial side. What's about the venous side? If you look at the base excess in the venous side, in a normal individual, you take whatever your patient, take an arterial blood and central venous blood, measure you go to the blood gas machine and you look at the base excess in the arterial, base excess in the venous. They are not equal, are different. You have 2-3 millimoles of difference. Why? Because base excess is relative to the standard ideal buffer base I have, which is 42, which include a bicarbonate 24.6, the albumin, etc., dissociated and so on. In a venous blood, my reference point is no more 42, because I have more bicarbonate, because I have more CO2. So my buffer base is greater. And so at the end, if I subtract, I have these 2-3 millimoles of difference. But if you know this, you can use the venous blood versus the arterial blood, keeping in account the baseline difference about 2 millimoles. But I think there is one thing which is important, because for me the central venous blood compared to the arterial, if you have also the pulse oximetry, give all the information of the arterial plus some additional information, the venous. And the venous blood, to me, the additional information is the Coca-Cola, the Coke effect. Because if you have one part of the body in which it generates some lactate or generates some acid, and put this acid in the blood, the venous blood, of course, you got the effect that you have when you put lemon in a Coke, you start to bubble. What is the bubble? The PCO2. The total amount of CO2 is exactly the same, but you change the dressing of the CO2. The CO2 is dressed as biocarbonate or as a free CO2 molecule. The sum of the two is the total CO2 in the blood, which is different from the total CO2 in the plasma, because the red cells have less CO2 than the plasma. But anyway, the concept is that more I put in the venous blood acid, greater is the amount of CO2, of the PCO2 I record. So we have an arterial of 40 or whatever it is, and the mixed venous or the central venous difference should be 3, 4, 5, 6, 7, 1 lamp, 8, 2 lamps, 10, definitely there is something absolutely wrong. And you have to understand why it's wrong, where this Coca-Cola comes from. And this is the importance of venous CO2 is very simple here. Just to give an example, let's see. These are the content of CO2, which is at the base excess of 0. We have about 50 milliliters of CO2 every 100 milliliters of blood. Okay, now, if I put the Coke, not the lemon, in the Coke, I increase the base excess, decrease the base excess, more negative, and of course I have less bicarbonate and I increase a lot the CO2. If you try a line here, you see that the PCO2 may go from 40 for the same amount of CO2 to 100. I don't know how many of you go in to make a fitness and so on. You take the weight and you start until you are exhausted. Try to take a blood when you do this one. It's not very common, but you can easily find that PCO2 in the arm is 120, 150. And in a normal, in a central venous blood, is not. And this is a classical Coca-Cola effect, because you are exhausted, you are full of lactic acid in that particular. Then when you go to the lung take care of the CO2. Okay? Now, I don't have to, so the difference between O2 and CO2 difference is crucial, but I don't have time to go into. So it's a marker or killer. If I ask you, if I have an extreme alkalosis, offer extreme acidosis, and I put the mortality, because the people love the mortality, not the mortality, that's the survival, but account for the mortality a lot, which is, I think, is a quite stupid way to approach medicine. Anyway, this is my personal view. What do you expect? Some U-shaped? No, these are extreme alkalosis, very, very low H plus concentration with a very great acidosis. And you see that the alkalosis is not associated to the big problem. Why? Because, my dear friend, alkalosis is a son of the doctors. Acidosis is son of the nature. We are not equipped against alkalosis. And the greatest cause of alkalosis is the most misused drug in intensive care, which is called furosemide. Because the people love to have 200 milliliters of urine per hour. If you look 200 milliliters of urine, you should go to the toilet every 1 hour. At my age, every 20 minutes. So you have to be extremely careful for that. So alkalosis is just an easy correct problem. Acidosis is a problem because acidosis is a sign of the most important thing for water intensive care burned, which is, intensive care in my view, is the prevention or the cure of the energy crisis. We are a thermodynamic crazy aspect because we are full of enthalpy, we have leaking membranes. And you say, why leaking membranes? Because all our enthalpy, so our free energy, or all the defect we have, apparently, give us a tremendous flexibility in response than if we as a stone in which the free energy is very slow. So the life is maintenance of a given level of energy. Anytime we have some energy crisis, which is oxygen consumption, is the energy production at the end of the story. DO2 and energy and all the servo mechanism to handle energy. Hemodynamic and respiration are just servo mechanisms to maintain two variables, O2 and CO2. Kidney, wasting product. Lung, wasting product and good for CO2. All the system is like this. And so we have a lot of things that give us an idea. A marker. We have low pH, high lactate, negative base excess, decreased CIT, higher PVCO2 are all. Don't ask me what is better, because it's the most stupid question. When people say wonderful question, means usually very stupid question. Because you cannot just look at one aspect of the reality. You have to look at the universe world. As a wind ventilator, I love the delta P. No, I love the mechanical power. No, I love the P. Doesn't mean anything to me. You have to look the entire and the whole picture. And that's time is running. I have 10 minutes, so I have to run it a bit. Let's see. This is lactate and pH. Look at the base excess. Minus 10, 10 to 5, minus 5 to 0, 0.5 here. This damn laser. Okay. You know, you have this base excess and you have this the pH. But look, there are certain points on which the lactate stay constant regardless the pH. And here, lactate stay more or less at the same level regardless the base excess. What does it mean? These are patients, a lot of patients in sepsis. So we introduce a very stupid concept, which is lactate, a lactic base excess. Very brief. You have the blood gases. You have minus 10 of base excess. You have lactate of 5. You add the lactate to the base excess. Minus 10 plus 5 is minus 5. Means that the base excess is justified only for 5 millimoles by the lactate. 5 other millimoles must come from other sources. If your alactic base excess is 0, means that all you have are due to the lactate. So this sum, you have just maybe 2 decimal, no decimal involved, so it's very easy, can you do in 5 seconds. Give you an idea of the alactic base excess. If alactic base excess is greater than 0, means very probably some volume contraction. If it's 0, means that all your base excess is justified by the lactate. If it's lower than 0, only one thing remains, unless you drink acid, which is the endogenous production in sepsis, is the kidney. And you have a beautiful relationship between creatinine and lactate base excess. So you have a blood gases. I would suggest you the central venous blood gases, looking for oxygenation, the pulse oximeter. All the rest can be said by the central venous. You may have computed the lactic base excess, you have a rapid. So how to correct heat? And I would like to just to go to the, at the end of the speech, sodium bicarbonate, dialysis, mechanical ventilations are all systems in which you may correct the pH. But as was my friend Michael was saying, before correction, take few minutes to sit down and to think why I should correct and which are the causes of what I observed. This is fundamental, because the first thing to do is to cure the disease. When we correct the pH, we do just a symptomatic treatment, because they say, okay, maybe the lower, very low pH per se may be dangerous. may cause may cause a further aggravation of the disease. So with the symptomatic treatment, when we abolish the symptom, we buy time. The same with the mechanical ventilation. The same with the hemodynamics when you give noradrenaline. In this case, we just buy time. We have to buy time at the lowest iatrogenic cost possible. As an example, if I want cure sodium bicarbonate with sodium bicarbonate and pH, low pH due to the respiratory acidosis, I do one of the most stupid things I can do, because I give an extra quota of CO2 in a patient in which the CO2 elimination is really the problem, and in which the buffer base is very increased because I have a lot of bicarbonate. So to change the pH, I need a lot of sodium, of different sodium. Anyway, just the last thing, and this is my personal life. We just published that in an abstract, I don't know how many decades ago. But when I was playing with acid-base equilibrium, which is sort of drug, you know, I think in my life every year I spend about 1 month in this computation and so on. Try to understand, because it's very easy to forget these kind of things. And I was taking a ship and by giving chlorine acid to the ship, so metabolic acidosis, keeping the CO2 constant through the mechanical ventilation. So the poor ship was acting as a tonometer. So I can make the curve of PCO2 40, base excess versus pH versus base excess. So reconstruct the Seagar-Anderson curve, which are the basis of most of our knowledge of this. And I knew that I could reach a very, very low level of pH without any problem for the ship. The ship is not very aggressive per se. The ship in anesthesia is even less aggressive. But, you know, the ship was extremely quiet from the homeostatic point of view ship. That means hemodynamic were okay. No apparent problem, urinary output was okay, etc., etc. In the room close to my room, there was a surgeon we were preparing for the liver transplant. And he wanted to see how long he could maintain the liver in warm liver, so at 37 degrees, without any perfusion. So to do that, clamp the aorta, clamp the vena cava, clamp the supraporta, and clamp the hepatic vein, and clamp the porta. And there was hemibody out of the circulation. After 30 minutes, declamp, plum. All the sheep, the young sheep, dead. And he said, okay, well, it's tremendous. The pH was 7.1. This 7.1 is not the cause of death. Cannot be. Now, try to do what's happened during the hemibody clamping. The cardiac output, what do you expect? Goes down. Circulate just and half. If I go down with the cardiac output and I do not change the mechanical ventilation, where the PCO2 goes? Around 20 instead of 40. At 20 of PCO2, biocarbonate is far lower. A great buffer is abolished. When I declamp, I have a load of acid coming from periphery. The Coca-Cola is a camion of a truck of Coca-Cola coming into the blood, and I have a sudden change of pH, arrhythmia, hemodynamic impairment, and death. So what's enough to do what? During the clamping, decrease the mechanical ventilation to maintain the entire CO2 constant. Immediately before and after, during the peri-clamping, increase the mechanical ventilation to clear up the Coca-Cola effect. The CO2 increases CO2 load coming from the Coca-Cola effect. Now, doing so, maintaining clamping and declamping, you see with the mechanical ventilation unadjusted, you have the PaCO2 during the, excuse me, where is this damn, okay. The PaCO2 goes down in an adjusted ventilation, the pH goes up, the potassium stays there, and the cardiac output goes down. When you adjust the mechanical ventilation, all this remains as the baseline. And at the end, you have this kind of difference. Results, unadjusted, all death. Adjusted, I think are dead now, but 30 years after the experiments were absolutely well. Only one message. As an example, I don't know how many anesthesiologists are here, but you declamp and declamp, as example, the aorta during some vascular surgery are not extreme situation. But how many look at entire CO2 and just the ventilation? This is one, because metabolic acidosis is one thing. Disturbances of the breath is another thing, but they are connected. Everything in biology is connected. And I thank you for the attention.
Thank you very much, Luciano. Questions from the audience? Of course, there will be a lot of questions because everyone knows at least the same than Luciano. So, it's a challenge after lunchtime, right? Okay. So if there are no questions, really not? As he told you, there are no stupid questions. and I can swear you, he doesn't give stupid answers. No?
I have a question.
Sorry, great.
Of course, I don't dare give you a question, Gianni, but I thought you were such a great performer, so maybe we would increase the entertainment. But what you say is that when you decrease the minute ventilation, you keep the CO2 high, and you also keep the bicarbonate high. Couldn't it be that it was just the buffer that you could use, so that when it was high, there was more buffer when you made the blood acidotic? Could you just have put another weak buffer instead of bicarbonate?
Well, theoretically, it's absolutely possible, but it's so easy to increase with entire. But is I think the interpretation, the only interpretation occurring in my mind, is the lack. You decrease the buffer power, and if I increase the albumin, increase the phosphate for the same amount of buffer power, I should have exactly the same effect, at least on the paper.
So we try with some more sheep.
Well, I thank you.
Further questions? If this is not the case, thank you very much,
Okay,
Luciano.
thank you to you.
So now we move to the next speaker, and as you were aware, this is an industrial symposium. Thank you very much for the company to organize it. And of course, if a company organizes such a meeting, they want to sell something, for sure. So what they are going to present, or what is going to be presented, how is it possible to influence these metabolic imbalances? And the device that you are going which you are going to see in the next minute, and the possibilities with regard to the correction of acidosis is now presented by Mr. Boenisch from Hamburgo. Please go ahead.
Any options to work with that? Okay. Hello, everybody. Who knows this gentleman? This is Michael Brecker. This is one of the most famous tenor saxophonists in our times, and a great improviser. And this is Pat Metheny, who's also a jazz giant. And Pat Metheny once said, the most treacherous job in jazz music is to play a solo after Michael Brecker played a solo. And I think I'm in the similar situation, because I'm the guy who has to give a talk after Luciano Gattinoni, which is really a challenge. And what can I add to this? But anyway, I try to do my very best, and I would like to share with you some insights on the treatment options for acidosis. And I was invited by this company, so I have to declare that. So you are all aware that we are dealing with a big problem, and we only have little evidence how we are going to work with that. And of course, there's a lot of arguing. And I like this, what John Callum and Rinaldo Bellomo wrote in a textbook for intensive care about acid-base regulation. As in other areas of controversy, the intensity of opinion is inversely proportional to the quality and amount of evidence available. And the problem we have is that our knowledge of today is mainly based on observational studies, expert opinion, a lot of animal studies, and experience in chronic kidney disease. And moreover, the data is conflicting. So how can we treat acidosis? So as Luciano already said, so we have to try to treat the underlying problem. This means we have to know it. The other thing that is absolutely necessary is that we have to optimize cardiovascular and respiratory system. Without that, we are not going to be successful. So for respiratory acidosis, which is defined by an increased CO2 and normal or increased base excess, so besides the cardiopulmonary stabilization and the causal therapy, we can give respiratory support to the patients and to increase the minute ventilation. And if this is not working, or if we are out of the borders of lung protective ventilation, we have to think about extracorporeal CO2 removal. With metabolic acidosis, we have also to pay attention that our cardiovascular and pulmonary system works. We have to go for the causal treatment. And then we have baking soda, so sodium bicarbonate. We can dialyze the patients, and we can think about giving respiratory support to the patients whose lungs are not able to compensate for the metabolic acidosis. So if we have metabolic acidosis, so we have either acid gain or base loss, and we can differentiate between them calculating the serum anion gap by subtracting chloride and bicarbonate concentration from the sodium concentration, and usually the normal concentration is up to 12 millimole per liters. And so with acid gain, we have increased anion gap because we are just consuming bicarbonate. In case of base loss, we have a normal anion gap because for every molecule of bicarbonate that fades, one molecule of chloride is reabsorbed. So we have hyperchloremic acidosis in this case with a normal anion gap. So if we have acid gain, we can think about increased acid production or decreased acid metabolism. In case of base loss, we can think whether this is a gastrointestinal loss or a renal loss. And for the mathematics under us, between us, they can calculate the urinary anion gap, which we won't do right now. So in this case, giving bicarbonate to the patient, this seems logical because we are losing bicarbonate. With acid gain, giving bicarbonate to patients who have an acid gain, things are way more complicated. So Luciano already presented the Stewart approach of acid-base, and I have to admit for myself that I have an intellectual problem with that. So I was very happy that I found this article from Story from 2016, which is a simplified Stewart model, which works perfectly well for me, at least. And the idea behind this is that changes in base excess, or let's say in base deficiency, might be a problem of chloride and sodium, of albumin, of lactate, and of the unmeasured anions. And so the pH in the end is influenced by the PCO2, which is clear, and then the base deficiency is composed of a base deficiency that comes from the relation between sodium and chloride, from albumin, from lactate, and by the unmeasured anions. And then I can calculate for all of these things so their contribution to the base deficiency. Luciano already explained the meaning of lactate with the several things that might contribute to lactic acidosis. And what I think what is very important that lactate can be converted into bicarbonate. So it's oxygen dependent. So, and this points to the fact that it's even more important to go for hemodynamic and respiratory stabilization of our patients. With the unmeasured anions, this is what remains after you subtract sodium chloride, albumin, lactate from the base deficiency. Then you have to see what are the possible options. We have phosphate and sulfates coming from the protein metabolism, which are usually excreted by the kidneys, and we have renal failure might add to that. We have ketoacidosis, which might be diabetic in nature or coming from starvation. And we have toxins following salicylate intoxication or toxic alcohols. And once we have this, we have to do the diagnostics and to do some lab investigations, and we have to go for the specific therapy. Of course, for instance, with ketoacidosis, so bicarbonate doesn't make sense. So the treatment is relatively easy. It's volume substitution and insulin therapy. With the intoxications, the best thing you might want to do is to dialyze the patient. So a couple of words about sodium bicarbonate. So what are the merits of it? So the merit might be that we overcome the myriads of problems associated with metabolic acidosis. At least this is what we hope. So we also hope that the negative adverse effects of bicarbonate might be not as significant as the benefits. What are the possible problems associated with bicarbonate therapy? This is first of all the thing that bicarbonate plus hydrogen is converts to carbonic acid, and this dissolves into CO2 and water. So in case we are not able, or a patient is not able to get rid of the CO2, we might create a respiratory acidosis. It is often discussed that we also might create an intracellular acidosis, which is probably even worse than the extracellular acidosis, but these observations are mainly derived from animal experiments. The other problems could be the decrease in ionized calcium, which might then decrease the myocardial contractility, hypernatremia, volume overload, hypokalemia, and metabolic alkalosis, which could also be bad and could, for instance, increase the binding of oxygen to hemoglobin, thereby impairing tissue oxygenation. The BICAR ICU study is more or less the only big randomized controlled clinical trial. It was done by Professor Jaber in Montpellier here in France. It's a French study. Several French ICUs participated in that. And they randomized around 400 patients with severe acidemia and serum lactate in two groups. The one group received IV sodium bicarbonate in order to maintain a pH of at least 7.3, and the other patients didn't get sodium bicarbonate. And so the primary endpoints of this study was day 21 mortality and at least one organ failure on day 7. And here you see the results of the thing. The laser, can I work with that? I don't know whether this works. Yeah, so here you have the overall mortality, and you see that this was not significant between the bicarbonate and the control group, although there was a certain trend. But what was obvious that in the group of patients with an acute kidney injury, 2 or 3, second or third degree, this was a predefined subgroup that was already in the preparation of the study. It was a predefined subgroup, and they stratified for that. There you had a better survival with bicarbonate therapy. And what was also striking, the secondary endpoint, the need of renal replacement therapy, and this was very obvious. There was a strong difference. The patients who received bicarbonate, the need of renal replacement therapy was way lower, and this was true for both the overall population as well as for the patients with acute kidney injury. So these results of the JABA study made it to the recommendations of the Surviving Sepsis campaign from last year. And so the recommendations are for adults with septic shock and hypoperfusion-induced lactic acidemia. We suggest against using sodium bicarbonate to improve hemodynamics or to reduce vasopressor requirements. And for the adults with septic shock and severe metabolic acidemia and acute injury, we suggest using sodium bicarbonate therapy. So for both recommendations, the quality of evidence is low. Nevertheless, they included the results of this study into the recommendation. What I think is very interesting, that sodium bicarbonate in lactic acidosis might increase lactate. And there are several reasons for that. The first reason is that the correction of the acidosis might increase the glucose metabolism, as seen here, and also impairing the lactate consumption and the lactate oxidation. And you also have the shock-promoting effects of bicarbonate-induced hypocalcemia, what I showed you earlier. And there's an interesting animal study from Kimun from 2014. They used an animal model of lactic acidosis. Lactic acidosis was induced by hemorrhagic shock, and they used an adapted bicarbonate therapy with a controlled hyperventilation in order to get rid of the overproduction of CO2 and additional calcium administration. And this resulted in improved hemodynamics. This is also was a retrospective study on the effects of sodium bicarbonate in patients with lactic acidosis, published in PLOS ONE. And after adjustment for other confounding factors, you had increased mortality in the patients who received sodium bicarbonate. And there have been a lot of indications for, or traditional indications for bicarbonate therapy. For instance, septic shock, lactic acidosis, diabetic ketoacidosis, cardiac arrest, and intraoperative metabolic acidosis. But in for none of these indications, the administration of bicarbonate showed a benefit. So what are alternatives to sodium bicarbonate? This is first tris buffer, carbicarb, and dichloroacetate. Carbicarb is a mixture of sodium bicarbonate and sodium carbonate, which produce less CO2 than bicarbonate alone. Tris is kind of an alcohol which is able to bind both hydrogen ions and CO2, and the protonized tris buffer can be excreted by the kidneys. So it's a good thing, but it is dependent on functioning kidneys. And dichloroacetate is more or less an experimental drug. That activates pyruvate dehydrogenase. This is the same, and so this means that the lactate metabolism is accelerated by this drug. It's the same thing we are doing with thiamine, which we are sometimes administrating to the patients, because thiamine is also increasing the function of the pyruvate dehydrogenase. Good, but anyway, for none of these substances, there was an advantage over bicarbonate. So what about dialysis? Here you see the three big studies on early versus late dialysis, and so it was always compared, kind of a prophylactic dialysis compared with a situation where an absolute indication was present, and you see in all these studies they used a pH of smaller than 7.15 or 7.2, and as you remember, in none of these studies there was an advantage for early dialysis. What could be the potential benefits of dialysis therapy is, first of all, we are we can remove acid components or metabolites plus base supplementation. Mostly the dialysis is more effective than when compared to bicarbonate infusion. We can also treat the concomitant problems with electrolytes and fluids. And of course, this is the basic idea of the therapy. We can remove water-soluble toxins. What are other problems with dialysis therapy? We have catheter-related issues with bleeding and infection. We can have patients with hemodynamic instability. We are immobilizing patients. We are also removing important substances, for instance, antibiotics. This is probably the reason why an increase in the dialysis dose in septic patients has negative impact on the outcome. We are also removing vitamins, amino acids, and phosphate. And we have bicarbonate-associated problems. And a typical problem is that in dialysis patients, we are going from a pre-dialytic acidosis state into a post-dialysis alkalosis state, particularly in the patients who are doing chronic dialysis. And you can see the various negative effects this can have. First of all, you have a strong increase in pH. This kind of influences the respiratory drive. If the CO2 is produced out of this, we are dependent on a good pulmonary function. Otherwise, we have an increase in pCO2 with hypoxia. And so this is a diagram from a paper on chronic kidney disease. But I think, as you can see here, what are the problems with the rapid increase in blood pH, respiratory changes, electrolyte imbalances, immune system deficiencies. I mean, although we have here something about progression of vascular calcifications, this is probably not the case or not the problem in the intensive care patients, but some of these things for sure play a role in the intensive care patients as well. And this is why nephrologists ask for the optimal pre-dialytic bicarbonate concentration and the best dialysate bicarbonate concentration. So now the regional anticoagulation with citrate is widespread, and this is as well an opportunity to treat metabolic acidosis, because the citrate is metabolized into bicarbonate in a ratio of 1:3. So if we have a patient who is dialyzed and is anticoagulated with citrate, we can treat a metabolic acidosis by increasing the citrate. So mostly we are increasing the blood flow, which is usually coupled to the citrate delivery, or we can also decrease the dialysate flow, because around 80% of the citrate calcium complex is removed from the circulation via the filter. So now I would like to present you this nice item. This was once upon a time, it was called ADVITOS. I think the company changed the name in 2016, I think. The device is now called ADVOS, Advanced Organ Support, because the title ADVITOS is kind of confusing, because it implies that the liver is the main target of the therapy. But in the end, the new device can remove albumin-bound toxins, water-soluble toxins, and as well CO2. So the three organs that the system is supporting are also the organs that are involved in acid-base regulation. And this is how the system works. We have an extracorporeal blood circuit, as in every dialysis system. We have a dialysate circuit. And the special feature in ADVOS is that albumin is added to the dialysate. We are talking about this later. And then this is a special feature of ADVOS. There is the ADVOS multi-circuit, which is meant to regenerate the albumin. So with the other albumin dialysis therapies, the used albumin is usually thrown away, but ADVOS can regenerate it, and this contributes to a long treatment time of 24 hours. And so by addition of either a basic concentrate or an acid concentrate, the albumin is regenerated, the bound toxins are removed, and the albumin can be reused for 24 hours. So, as I said, the primary goal of this multi-circuit, the typical ADVOS circuit, was the regeneration of the albumin, but it has also therapeutic implications for acidosis therapy, as we are able to customize the dialysate. So we can adjust the pH, we can adjust the bicarbonate concentration, as well as sodium and chloride. And this is the in ex vivo study that was performed by Dr. Perez from the ADVITOS company, published in Intensive Care Medicine Experimental in 2019. This was the ex vivo proof of the concept, and what was done, the colleagues used a blood pool of 5 liters of swine blood, and this was used in the ADVOS therapy, and a respiratory as well as a metabolic acidosis was simulated by infusion of either CO2 or lactic acid. Then they assessed whether the system can remove CO2 and how the system can influence the acid-base situation under various conditions. For instance, they changed the blood flow, they changed the dialysate pH and the bicarbonate concentration, as well as the concentrate flow. And they also compared the ADVOS therapy with conventional dialysis therapies. So, and here you see what happened with the CO2 removal. So you see that the various conditions, different dialysates, pH, different blood flows, different concentrate flows, and you see that in some conditions there were very abnormal PCO2s and bicarbonate concentrations, but under specific conditions you had really a strong remove of CO2, while the PCO2 and the bicarbonate were in physiologic ranges. This was the case here in what you see here on the right side. And when you performed an experiment with hypercapnic acidosis, this was the hypercapnic acidosis was induced by CO2 infusion, and you see in the preparation time how the pH decreases and the PCO2 increases. Then in the treatment phase, the pH was quickly corrected within 1 hour, more or less, from 7.1 to 7.35. And the PCO2, you see that it strongly decreased from over 100 to normal values. The same was true with metabolic acidosis, which was induced by infusion of lactic acid. And so under the different conditions, you could see that an acid loss of up to 3 millimole per minute was easy to correct with the system. And here you also have another experiment where ADVOS was compared to conventional therapy, CVVH, and you see that the pH with the ADVOS therapy on the left side, you see in the treatment phase how the pH goes up, and this was not possible with hemofiltration. And you also see the PCO2 and the bicarbonate concentrates, and you see that with hemofiltration, the CO2 goes up and goes up and goes up, while it is well controlled with ADVOS therapy. So what are the main results from the ex vivo experiments? That ADVOS can remove around 60 ml of CO2 per minute with a blood flow of 400 milliliters per minute and a bicarbonate-free dialysate at a pH of 10. This is kind of important because most of the conventional dialysis systems, they have bicarbonate. But bicarbonate is kind of a power that is kind of preventing the removal of CO2 because it's the other direction of the chemical reaction. And with this concept, so you had normal blood PCO2 and normal bicarbonate concentrates. So with the system, it's even possible to remove more than 60 ml of CO2, but then PCO2 and bicarbonate concentrations were out of the physiologic range. So ADVOS can also compensate an acid load of up to 3 millimole per minute and normalize pH and CO2 in 1 hour, which is not possible with either hemofiltration or continuous veno-venous hemodialysis. I would like to share with you some of the Hamburg experience. I am from Hamburg, and this was done in our department. So we investigated the clinical course of 34 patients with multi-organ failure and including acute kidney injury. And we also did a subgroup analysis for patients with ARDS and severe metabolic acidosis. And what you can see here that in all the groups, so in the overall group on the left side, in the RDS group in the middle, and in the group with patients with severe metabolic acidosis, there was a very good correction of the pH. You see in the overall group from 7.29 to normal values, RDS from 7.2 to normal values, and in the acidosis group as well from 7.19 to normal values. And of the 11 patients with severe acidosis, 6 had refractory acidosis, which we were not able to treat with conventional dialysis therapy. And in the group of patients with ARDS, you see that we were able, during the treatment, to reduce both the driving pressure as well as the maximal inspiratory pressure, and we were therefore able to provide lung protective ventilation. And you also saw cardiovascular improvement with a significant reduction in noradrenaline doses. So the same was true with the patients with severe acidosis, who had a significant reduction depending on the initial dose. And this was accompanied by a survival that was better than it was expected. So based on the SOFA scores the patients had, you see we expected from the SOFA scores, we expected a survival of 20%, and we had we observed a survival of 50%. So this is data from the use of ADVOS in COVID-19 patients. So this was done in Munich, 9 patients with COVID-19 ARDS. And
Olaf, you have to get to the end.
Yeah, so I come to the end.
I don't want to hurry you, but you
No,
have to stay in time. Okay?
Yeah. Okay, that's fine. So you see that the blood pH increases in these patients. So after the first session, and from baseline to the last ADVOS session, you see the significant decrease in the PaCO2. So why does ADVOS works? So the main thing is that you can customize the dialysate composition. So first of all, you have albumin in the dialysate, which acts as the main buffer. Then you can kind of adjust the dialysate pH between 7.2 and 10 by the different adjustment of acidic concentrate and alkaline concentrate. The CO2 removal follows the diffusion of hydrogen ions and bicarbonate from blood to dialysate, which is similar to the function of the kidneys. So, let's skip that. So what are the advantages of ADVOS compared to other extracorporeal therapies? So the first thing is that you have one device that supports 3 organ systems, which means that we have less extracorporeal blood volume, and there are also economic aspects related to that. It works with low blood flow. This means that we can use conventional dialysis catheters. We don't have the bicarbonate-associated CO2 load. We don't have a gas phase. And the treatment is well tolerated, and there were no major adverse effects contributable to ADVOS. However, there are a lot of questions remaining. For instance, so what therapy do we do depending on the underlying disease? What is the trigger at which pH we want to start the therapy? What is the target of the therapy? Is it 7.2? Is it 7.3? We don't know. What about the different compartments, extracellular pH, intracellular pH? What about the tempo of pH regulation? Should we rather use bicarbonate or should we directly dialyze the patients? And in the end, what is the best RRT modality? Is it CVVH? Is it ADVOS? So we don't know that. And to get more answers into that, there are a couple of randomized controlled trials planned. So first of all, this is a study that we are planning, for instance, also in Hamburg, a comparison between ADVOS and conventional hemodialysis for pH correction in critically ill patients. And the other study will be performed mainly in Mainz, ADVOS versus conventional hemodialysis in patients with ACLF. Who knows that woman? It's my last slide. Who's that? It's Marie Curie. This was the first female professor here in Paris at the Sorbonne University. And she said, nothing in life is to be feared, it is only to be understood. Thank you for your attention.
Thank you very much. I would allow one question. A second one is shut down. No, but are there any questions? So if this is not true, I have to thank you for sharing this, I would say, active break. So normally active break means you move your body. In this case, you moved your brain. So you lost already some of the calories that you were taking in. So have a nice afternoon. Bye-bye.